Good day. This is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome everyone to our weekly webinar series entitled Medical and Public Health Considerations of COVID-19. Today we have two wonderful presentations. The first one will be on acute kidney injury during COVID-19, and the second one will be an update from the front lines, protesters, tear gas, and COVID-19. Given both presentations and clearly the interest in both of these topics, we'll probably run a little bit long today with the goal of ending about 4:15 so we can take in a full Q&A session. Next slide. I'd like to thank all of our partnering societies. Next slide. This webinar will be recorded and will be posted on the ACMT website within 48 hours on Friday. The other webinars that we've put on can be found on the website at acmt.net/COVID-19 web. And any questions about this series can be addressed to info@acmt.net. Next slide. There will be a Q&A at the end of the session as described. Please chat in your questions either into the chat box or the Q&A box on the WebEx, or if you're on YouTube, you can chat in your questions into the chat function on YouTube or Facebook Live. Next slide. There are no conflicts of interest with any of the speakers. Next slide. I'd like to welcome and thank my co-moderator today, Joshua King. Josh has the distinction of being both a board-certified nephrologist as well as a board-certified medical toxicologist, and he will help lead the discussion after the presentations. Next slide. At this point, it's really my great honor of introducing our first speaker. I've known Jonathan Barasch for approximately 45 years, dating back to our college days at Dartmouth College. And John has gone on to become a world-renowned research nephrologist. He's a professor of medicine and pathology and cell biology at Columbia University, physician and sciences medical school, and has spent really a lifetime looking at basic understandings of kidney pathophysiology and the role of biomarkers in the kidney. Columbia was particularly hit hard with the COVID-19 pandemic at the apex during March and April. And John will be sharing some reflections about current definitions of acute kidney injury, the role of biomarkers, and COVID-19. Thank you, John.
Okay, well, thank you, Dr. Wax, for the introduction. So I'd like to discuss with you this idea of acute kidney injury, its definition, how the definition has changed over time. And given our definitional issues, how to think about the COVID event. COVID has essentially presented us with a myriad of patients on the orders of dozens of patients per day with acute kidney injury as currently defined, and has left us with many questions about diagnosis and definition. Let me begin. So I'd like the audience to step back for a minute and think about seeing a patient in an emergency room. And we can see patients in emergency rooms who have low blood pressure. They may have pneumonia. We frequently see this scenario and the patient simply wants to go home. But a lab test comes back with a creatinine of 1.5. And we're consider a diagnosis called acute kidney injury. Should the patient be kept in the hospital, or what should we do? Creatinine is 1. Are you safe to do so or not? So these are very simple, straightforward, bread and butter issues that arise because of our problems of definition of using creatinine as a sole marker of renal injury at the moment. So, creatinine is a steady state marker of kidney function. And it works because we measure a ratio of urine creatinine, shown in yellow there, and plasma creatinine. And that ratio is equal to the filtration rate of the kidney. The key thing in the equation to think about creatinine is that it only represents the filtration function of the kidney at steady state. The equal sign is a very significant part of the equation. This equation, the creatinine in the urine versus creatinine in the plasma, is only valid measure of kidney function at steady state. And this is because what it does is it allows us to think about creatinine entering the glomerulus and leaving the glomerulus into the urine in a continuous flow. Obviously, during a setting of kidney disease, we don't have a continuous flow. And the production of creatinine can be changed, for example, in sepsis. And its entry into the kidney and its disposal in the urine is obviously quite different. In fact, those parameters change hour by hour, if not day by day. So the use of a creatinine to measure renal function in acute kidney injury, as it's called, and rapid changes in kidney function, is an invalid measurement. One can't determine function using creatinine in that setting. But here's the problem. Here's the even deeper problem. The level of creatinine is considered paramount to the definition of acute kidney injury. So in other words, the greater the increase in creatinine, the greater the scaling of injury along these types of scales called the Rifle scale, the Aiken scale, the KDIGO scale, RIFL. You can see that on this purple part of the diagram, on this purple trapezoid, an increase in creatinine gives you a higher stage, as it's called, of renal failure. But the use of creatinine is, remember, for a steady state function of the kidney and is not specific to the injury of the kidney. In fact, creatinine, as you know, comes from muscle cells. It doesn't arise from kidney cells. But yet its accumulation in the serum is tantamount to considered to be renal injury. Therein is the problem, and therein is some of the issues with the diagnosis of COVID disease, since we only have this single agent. These couple of slides show the problem in greater detail. A newborn baby in an intensive care unit at the red asterisk there in the first panel has a birth injury that creates hypoxia and renal failure. But you can see from the curve, the creatinine only goes up very slowly. And it's not till day 5 or 6 that the neonatologist noticed that there's acute kidney injury. Over to your right, you see a child undergoing an operation, a cardiac replacement, a valve replacement. And what you see is that in the green bar is that creatinine only reaches the diagnostic level for AKI, as it's called, many, many days later after the operation occurs at the red asterisk. So in addition to being a delayed marker, it's also insensitive. The bottom panel shows the beginning of hydronephrosis, where on the right side of that CAT scan, where the arrow is. But you can see in the middle panel that there's no elevation of creatinine in unilateral hydronephrosis at the beginning. In fact, you can remove a kidney from a patient as a kidney donor, and the mean average creatinine 30 years later is on the order of 1.4 or so, just at the upper limit of normal. So creatinine is also very insensitive to injury. In fact, if you can take out a piece of a kidney, there could be no change in creatinine whatsoever. In panel number 3, we see the causes of creatinine increase. It's obviously quite variable, and so creatinine doesn't give us, this functional marker does not give us insight into injury or into the clinical scenario. And in fact, if you look at the bottom panel, the vast majority of patients resolve their creatinine level by day 2 or 3. So in the bottom panel, we studied 3.8 million patients at the New York Presbyterian Hospital, the databases. And we asked the question is, if a patient meets criteria for AKI on the basis of serum creatinine, how long does it take to resolve? And what you see in this chart on the left, what you see is that patients will resolve, about 33% of patients will resolve by day 1 after admission from the emergency room, and about 50% or so by day 2, and about 75% by day 3. So most elevations of serum creatinine are not the type of injury that we think about in tissue damage. They are a change in creatinine that resolves very quickly on entry and probably relates to volume status and what used to be called prerenal azotemia. And that would be reversed very quickly by providing extra fluids. On the right side, you see that any cause of a decrease increase in creatinine and a decreased flow into the kidney and excretory capacity of the kidney is a serious matter, because in every circumstance, those lines, elevated lines, are electrolyte abnormalities. And they do occur immediately. Even 1 day of an elevated creatinine provides for electrolyte abnormalities. But nonetheless, the reversibility of the situation in up to 75% of people means that the patients coming into the emergency room typically is what we used to call prerenal azotemia. And the question here is, do they really have an injury of their kidney? So this chart lends further doubt to this idea that creatinine, a functional marker, is telling us about tubular injury in specific. Here, Chirag Parikh of Johns Hopkins University has placed on the first axis facing you elevated creatinine along one of our typical scales called Aiken scales, stage 1, 2, and 3. And on the axis going back in the field, the z-axis, what you notice is that those that have sustained elevations of serum creatinine are at much more risk of disease, death, and disability than those with shorter elevations. So a transient elevation of serum creatinine for very few days is much less toxic than a sustained elevation of even much lower creatinine level, for instance, the white bar all the way in the back, for longer periods of time. It's the length of time that creatinine is elevated that seems to correlate with biological injury, not the degree of elevation of creatinine as the scales would indicate. So this tells us that in a place like in the emergency room, where one is using only a single creatinine measurement at one time, it's very difficult to make a diagnosis that clearly. Many of us have been studying how the kidney responds to damage, and what we see is a variety of proteins are produced by kidney tubules in damage. Here's one that we and many other people have picked up. It's called NGAL, or Neutrophil Gelatinase-associated Lipocalin. It's a small molecule. It's a protein shown on the right, and it has a pocket inside its calyx. The calyx is shown in the blue area, and it binds to these organic molecules shown on the left side, which are called bacterial siderophores. This is a molecule that's made as an antimicrobial agent by damaged kidneys in order to capture these iron-related products, as you see there on the left side, that are made by bacteria. And once it's released into the urine, it's a bacteriostatic agent. It's one of the first responses that a damaged kidney will make to release this bacteriostatic agent. It grabs onto these organic molecules produced by bacteria, which are involved in stealing our iron. So Roland Strong at the Fred Hutchinson Institute crystallized NGAL and found this bacterial molecule shown on the left inside the pocket of the protein, and declared this to be a member of what's called the innate immunity. And it's the first response, one of the rapid responses that damaged kidneys make to injury of different types. So you can see in this slide that a control kidney has very little of this protein, this NGAL protein. We're looking at the RNA for it, by the way. And volume depletion, where we take this is a mouse model where we take mice and volume deplete them. We don't give them food or water for 3 days. And those animals lose about 30% of their body weight, or so, 20 to 30% of their body weight. You basically do not see the protein being made. But if you do 10 minutes of ischemia to the artery, the renal artery of the mouse, you can see a lot of this protein being made. So it's a protein that does not respond to the volume depletion. Remember all the patients coming to the emergency room who resolve very quickly. Most of those are volume depleted patients, but it only responds when there's real prolonged, significant ischemic damage. You can see this by ligating an artery in the mouse going to one part of the kidney. So to the left, to the right side of the kidney there, you can see the blue staining typical of this NGAL protein being made. But on the left side, where we did not ligate the branched artery, you don't see it. So this is a protein that comes up in tubular damage and doesn't seem to come up much in volume depletion. In fact, to prove the point, we put a luciferase a molecule, a fluorescent, a glow-in-the-dark type molecule into the gene for this NGAL gene. And instead of making NGAL, it made luciferase, and therefore you could see the light emanating from living mice. And when those kidneys are ischemic, they release light. And the amount is dose responsive. 30 minutes of ischemia, they're in the middle panel. A lot, 15 minutes of ischemia, less. And you can see all the way on the right that when the mouse is volume depleted by no food and no water, you don't get the protein. So here we have a protein that clearly distinguishes types of elevated creatinine. We went to the human, and here you see in red by the RNA for NGAL, and in situ hybridization. The blue staining is the collecting ducts, and you can see that a lot of this NGAL protein in red is made by collecting ducts and cells in the collecting duct. There's a scattering of other parts of the kidney that also make it, as you can see from this image. Way up in the proximal tubule are the lighter zones between the collecting ducts that have the least amount of NGAL expression. The human has surprised us because there's a tremendous amount of this protein there, probably more than in the mouse model. So this is a human with a nephrectomy. Nephrectomies do require an ischemic time, about 15 minutes. And this shows the expression of the activation of this NGAL protein shown in red. This next slide is what old-time images used to look like, also looking at the RNA. These are probably limbs of Henle, where the protein is also expressed. Now, going to our slide here, we see a variety of clinical studies. And the question for the clinical studies is compared to the creatinine in the black line in the first panel there on the top left, is how does the NGAL protein compare in this case? Now, we've studied many, many biomarkers, and I highlight NGAL simply because it's the one I've worked on most, but KIM1 is also can fall along some of these types of images as well, in particular. And what you see is that the red arrow there up on the left panel is the operation, is the birth injury in this case. This is a neonatal birth injury. And you see creatinines in the black line slowly elevating. The NGAL protein moves up much faster. It's in the blue. So it comes up sort of very almost on the first day and then spikes before the creatinine even spikes. If you move over to the right top panel, what you see also is in the blue line, the NGAL level in patients who have elevated creatinine measured at the green bar a few days later. So it spikes here in about 2 hours in the urine in the case of this paper by Prasad Devarajan. In the bottom panel, also one of his papers, Dr. Devarajan's papers, what you can see is that what's called the AUC-ROC, in other words, the association of NGAL with a subsequent elevation of creatinine is really, really exciting when you observe NGAL protein early after the injury, in other words, in this case, cardiac surgery. If you look later and later over time, that relationship in the black line in the AUC-ROC curve is maintained, but the other biomarkers are now pretty good over time. So NGAL comes up first. It's a very early protein and associates with a subsequent injury. The type of injury is ischemic damage of the nephron or toxic damage of the nephron. And that, you see in one of Dr. Devarajan's panels up on the left side at the top, NGAL in red comes up pretty early. The other biomarkers come up as well a little bit later, hours later. So we like NGAL for its rapidity. We also like it if you look at the bottom panel that even a single, in the yellow there, even a single obstruction of one kidney provides NGAL expression, where the creatinine did not show that because the creatinine is pretty insensitive, but you get NGAL in the bilateral one, which is the taller yellow column, you get double the amount of NGAL. So it's very dose dependent and elevated. And most importantly, if you look at the panels on the top and on the bottom on the right side, you see it associates with the ischemic diseases in all these patients. Each lane of that gel is a different patient, as summarized in the panel below. So volume-related things, which are 75% of our cases, do not make this protein, nor it turns out any other biomarker. We next went to 1,650 patients from around the world, and this slide requires a bit of time to look at, which I'll let you do offline, but you can see that transient elevations, it says trans on the top, have much less of the various biomarkers than sustained elevations of creatinine. And if you look all the way on the right side, you can see that a creatinine of 1.4 and an NGAL level of greater than 104 in the bottom panel, and a KIM level of greater than 2.8 in the emergency room, when you've only had one creatinine measurement, associates with a 15% death rate or dialysis rate within the following 7 days. It's a quite extraordinary thing to see that even when the creatinine is low, and you can look at the second column, less than 1.4 for creatinine, if the biomarker is present, 104 of NGAL in the second line there, or greater than 2.8 of KIM in the bottom, there's a 5% chance of death or dialysis. And the ER doctor wouldn't have known that because they are looking at a lower creatinine. But the biomarker is saying things are happening that the creatinine, the functional marker, doesn't detect quite yet. And then, as I said, the last column is the combination of them, which shows a very significant degree of risk for the patient. And in this slide, we see exactly the same information, which you can look at on your own, but essentially that volume depletion transient, which you can see on the right side on the top, doesn't make much of this protein NGAL, whereas sustained does. And some numbers on the bottom from Chirag Parikh in a similar type of study. This is a set of cirrhotic patients. Now, there is a dipstick for NGAL, which we've been looking at. Obviously, a dipstick is very qualitative, but it gives you a sort of a rapid view of, in the urine, the high level of NGAL shown in the bottom dipstick, correlates with our classical ELISA measurements. And those patients are more likely to have subsequent sustained elevations of creatinine once they enter the hospital. This is another emergency room study. The genes that we make on ischemia reperfusion are just different than the genes we make in volume depletion. We make new genes in both cases, but they are different. Even though the creatinines may be elevated in both, it's not identical. The list of genes is different. And this is called a pathway analysis, where we take all the genes and put it into a computer and ask, well, what's happening? And for ischemic disease, we see fibrin clotting genes, cytokine activation genes, but in the volume depleted genes, in red there on the bottom of we're looking at the left side on the bottom red bar, we only see metabolic genes. So the genes are different. The types of genes, the pathways they subtend are completely different in these settings. This slide summarizes the things I've said so far. In other words, you have a stimulus and then the cell responds with new genes. Then the cell goes on to be damaged. And then eventually we get to organ failure, which is the rise of creatinine. Troponin in the heart is kind of like NGAL and the other biomarkers, KIM1 and other biomarkers that take a central middle place in this pathway that tell you that there's damage, but not yet organ failure. So our problem in nephrology is we use a marker of organ failure to define injury, which may or may not result in organ failure. As we know, injuries can be mild, moderate, or severe, and there's only the severe ones represent organ failure. This slide you can look at on your own, and it basically summarizes the idea of how to think about creatinine plus these biomarkers together. So you can be creatinine positive, biomarker positive. That's a very bad situation. That would be at the bottom right. Or you can have one positive and the other negative, and those would be the other two boxes, or negative, negative, which would be normal. So there's a growing sophistication that we should think about creatinine, a marker of organ failure, and an injury marker, which is one of the biomarkers, and how do we combine them to plus, 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 minus, minus, plus, and minus, minus, and how does that relate to patient outcomes? I'd like to caution you that an L-creatinine on the setting of diuretics, which is shown here, you can look at the X panel. This is work from Dr. Testani at Yale, basically shows an elevation of creatinine in the setting of diuretics with no increase of three different biomarkers. Again, we can reduce the flow into the kidney, reduces function, but not yet injure the nephron. All of these data separate the idea that creatinine is really an AKI marker. It really isn't. It's an acute renal failure marker. And this summarizes those data. That most changes in creatinine are due to volume events and are short-lived. And those that are not short-lived, we likely to consider tubular injury. Now let's go to COVID in section. Let's think about COVID and how that looks like. At my university, we have seen so many patients arriving all at the same time, sort of after March 20th. It was between March 20th and the end of April. A continuous stream of patients with COVID and respiratory disease, as well as with kidney disease. So before COVID, we have to recognize that between 22 and 44, let's say 30% of patients with ARDS would have a change in creatinine that would invoke a renal consult with the question of whether there's tubular damage or not. So that's sort of a comparator group. It's not that tremendously different in the world of the COVID AKI. Although the following we've seen, the types of damage we see is always sustained AKI. It's not the transient forms that I've been talking about, number one. Number two is that those patients with AKI and COVID are usually people who are already on pressors and are frequently have severe dyspnea and are headed to an intensive care unit, and that is 10 new patients per day. Of those 10 new patients per day, 2 to 3 will go on dialysis, and they will require CVVH every single day. And they are on dialysis for greater than 2 weeks, some up to 4 weeks. 1/5 will come off dialysis, 2/5 will die. What this means is that ARDS plus AKI is a very well-known phenomenon and consistent with previous ARDS, but in this case, everyone is presenting at the same time, and the number of patients accumulate per day, meaning that the various clinical people in my institution had to do very clever things with the CVVH machines on one day, off another day, and other types of sharing modalities. Eventually, a third of our ICU was required back for COVID-related AKI, and then sort of up into the 50% range. Our pathology from these vary over, and the message from kidney biopsies, our pathologists have done many kidney biopsies, we've examined them, and the take-home message is that there's a variety of pathologies, many of which are inflammatory. So one can see a variety of glomerular diseases, focal sclerosis, membranous, minimal change disease, and a variety of diseases. But the overall feeling is that there's a lot of inflammatory disease in the kidney. So we have to ask the question, since these patients have remained on severe volume depletion to limit the problem of pulmonary edema and have been kept very dry, we have proposed initially that this is all a volume depleted disease that just sort of went too far. We don't know exactly the order of business here and the timing, but what I can tell you from the biomarkers, NGAL on one side here on your left and Kim on the right, there's a tremendous exuberant expression of these biomarkers within those kidney biopsies. Therefore, we do not believe that this is a volume-related event, because the volume-related events, as I showed you, do not really activate these proteins, these genes very much. This is real tubular injury. So that's our first take-home message. The second thing is a beautiful little study was published about the urine, and what are called muddy brown casts, which you can see all the way on the right side, are typical of this disease. And those muddy brown casts in the urine are typical of tubular damage. So we're not looking at volume depletion, which is 75% of regular pre-COVID patients coming into the hospital. But what we're looking at is tubular damage on the basis of biomarkers and these very nice urine studies from this group. Now, COVID is COVID in the kidney and the cause of it. And I'd like to show you the middle picture is the lung with COVID. These are my pictures. The right side is the kidney. Now, I have to say that this is a very rare event. It is very hard to see COVID in the kidney. We had to look very hard through thousands of sections and many, many biopsies. And overall, we are not impressed with the level of little spots that may or may not be COVID in the kidney. We do not think AKI is due to COVID invasion of the kidney. Yes, we think there's some COVID in some biopsies, but it doesn't explain all of the patients that we've seen. We do not believe that's the cause. Some people think that this could be due to ACE inhibitors, and the story there briefly goes as follows. The molecule ACE2, which is shown in green, is the receptor for COVID in the kidney, as well as in the nose and in the airway and in the lung. And ACE2 is a very important molecule because it takes angiotensin 1, you can see at the top of the slide, and angiotensin 2, you can see in the middle of the slide, and turns those vasoconstrictors into vasodilators, which is angiotensin 1 to 7. 1 to 7 binds to different receptors than angiotensin 2 does. And it's sort of the balance between the vasoconstrictor, angiotensin 2, and 1 through 7, the vasodilator, that is important to normal blood pressure control and blood flow into the kidney. And it is thought that the virus binds to ACE2 and removes it from the cell surface and therefore disables this pathway going over to the right to make these vasodilators. It's a very interesting and complicated system. This is a brilliant review article, by the way, and I recommend it. But basically what it shows is that when you make the vasoconstrictor, you tend to turn off ACE2, the ACE2 for the vasodilator as well. The blue bolt here is pointing to atom 17, which is turned on by angiotensin 2 rather, and it disables by proteolysis ACE2. It releases it. It's also thought on the right side that the virus enters and disables ACE2 and therefore leaving the angiotensin 2 unopposed. Some people say that ACE inhibitors from studies could be beneficial, and they would be beneficial simply by reducing, as you can see in the middle panel, by the level of angiotensin 2 that's made the vasoconstrictor. And this is pretty well established in different lung diseases. And it's felt that maybe you could reduce angiotensin 2 and that would diminish the vasoconstriction or the disease that may affect the lung. Also, angiotensin 2, as is shown by the lightning bolt, the blue lightning bolt in the middle, remember, activates an enzyme that disables ACE2. So if you block this system and block angiotensin 2, you would have more ACE2 and therefore more vasodilatory actions of Ang 1 through 7 rather than angiotensin 2. So some people have said that ACE inhibitors or ARBs are very useful in these diseases because you're allowing you're protecting the vasodilatory pathways by allowing ACE2 not to be degraded in an angiotensin 2 dependent manner. And this is of consideration. On the other hand, other investigators have proposed, and I recommend this article, have proposed that because ACE2 may be protected by these ACE inhibitors, it may provide more docking for virus, and that's what you see all the way on the right side, enhancing infection. And the way that this particular author puts this together is that while ACEs and ARBs may encourage infection initially, once the damage begins in a variety of organs, they may be beneficial because they may protect ACE2, which has been shown to allow for less severe disease. Now, all of this has gone to a variety of small clinical studies. I have to mention that some of them have been retracted because of lack of being able to trace data that clearly, and data sets may not have been as good as initially thought. But no randomized clinical trial has been done. But this paper gives us at least a roadmap to thinking about the fact that maybe the patient should not be on maybe these would be pro-inflammatory, pro-infectious to be on ACE2, ACE inhibitors and ARBs, because it would enhance ACE2 levels, the viral receptor. But on the other hand, once the disease starts, it may be beneficial to remove angiotensin 2, allow ACE to reactivate ACE2 to reactivate to give us the beneficial Ang 1 through 7. The jury seems to be completely out, and I recently reviewed the literature. And of course, no randomized clinical trial probably could ever be done at this point. But that's the thinking in it. So is this a viral invasion of the kidney that's causing AKI? We don't think so. Is this a volume depleted, the standard typical thing you see in an emergency department coming in? No, absolutely not. This is a very intense biomarker positive event. And we think that the whole idea, essentially in the summary here, basically comes down to a type of inflammatory acute kidney injury, the type of thing that one sees in sepsis, where, of course, one doesn't need bacteria in the kidney to cause AKI, or to cause tubular damage, but the inflammatory events that occur have thought to be the problem. Whether it's an interferon signal, which some people believe it is, or whether it's other types of cytokines, remains to be seen. GCSF is a possibility. Interferons are a possibility. People have focused on interleukin-6 as a major type, or interleukin-1 as a major type. That's unclear, but the data in biopsies and through all these studies seem to suggest that this is a real tubular injury with a rich inflammatory response, typical of other acute tubular injuries. Volume depletion, which is also called AKI and should not be called AKI, is a completely different kettle of fish and is probably there to prolong life by counter-activating volume depletion. What we're talking about here is an inflammatory disease in COVID AKI. Inflammatory not directly, but indirectly through viral infection, probably in the lung. So if you imagine your patient coming in with a creatinine of 1.7, the question in an emergency room is it going to go up or is it going to go down? And ER docs don't have the luxury of time. You can't keep the patient there for 12 hours just to check a creatinine. If you diurese someone and their creatinine goes up to 2, what do? You don't have necessarily the luxury of time or the safety issues with the patient. You stop the diuretics, you continue them. If a patient obviously is going to have a rhabdomyolysis of the kidney, but the creatinine's 1, what does that mean? So this goes to show that we need a new level of sophistication in thinking about AKI. And that new level of sophistication has helped us with the COVID to classify it as an inflammatory type of acute tubular injury. So my lab is here and contributed to this talk. And I thank you for allowing me to present today.
Thank you very much, Dr. Barasch. That was a really wonderful and erudite presentation, very much cutting-edge research and its clinical applicability. And I'm sure there'll be many questions in the Q&A. And those of you on the webinar, please type in your questions either into the chat function or to the Q&A function. So before we get to the Q&A, we're going to go to the next presentation. And my colleague and co-moderator, next slide, please, Adrian. My colleague and co-moderator for our weekly series, Dr. Ziad Kazi, who's a board member of ACMT and also the president of the North African and Middle East Clinical Toxicology Society. He will introduce the speakers for the next brief. Dr. Kazi.
Thank you, Dr. Wax. Dr. Barasch, thank you so much for an amazing presentation. I've learned so much from it, and I really appreciate you sharing this valuable information. Now, for the second part of our didactic, for the second part of our webinar today, we are going to move to the updates from the front lines. This has been a popular part of our webinar series, and it's our pleasure today to talk about protesters, tear gas, and COVID-19. We felt that this topic, in view of recent events, would be of interest to our audience, and we invited 2 colleagues from ACMT, from Thailand and Lebanon, to share with us their valuable expertise. Specifically today, I will start by, exposed to tear gas, you are going to potentially remove the mask to breathe better. This is at a time when you will be coughing and potentially releasing additional virus. So all of these factors really support the potential for increased transmission during protests of the virus. Additionally, the specific effect of tear gas chemicals has been studied by the military, actually, where, for example, the chemical CS is used in military training. And there are some studies looking at associations between exposure to CS during training by the military and the occurrence of acute respiratory illnesses like influenza, for example, in the couple of weeks ensuing the exercise. Raising again this concern about increased coronavirus transmission during these protests. Now, again, these protests, like I said, include tear gas injuries, but also have other types of injuries. And for that, I want to actually ask Dr. Tharwat Zahran to share with us valuable information and data that she's collected. This data is not going to be included in your handout because it is being submitted for publication, but it's our pleasure to hear from her a summary of what she has identified from her experience. Dr. Tharwat?
Thank you, Dr. Kazi. So we performed a secondary analysis of all the patients who presented to our ABMC emergency department with riot-related injuries between October 17 and February 29 of this year. And the aim was to improve our emergency preparedness plan and resource utilization. We had a total of 313 patients, and on peak days, we had one patient arrive every 3 minutes. The mean age of the victims was about 30 years, with the majority being males, 91%, and most were from the protesters, with a minority being from the policemen. So to avoid conflicts, we had to separate them in separate sections in the ED. The most common mode of transport to the ED was through EMS, and hence effective communication and planning between EMS and the ED staff is crucial. On arrival, the majority of the patients had an emergency severity score of 3. And the most common reported mechanism of injury was by stones, rocks, tear gas canisters, projectile objects, and tear gas inhalation exposures accounted for 11%, and the rest are broken down as in the table. Extremity injuries were the most common, frequently injured body region, followed by head, face, and neck, and polytrauma. Laceration injuries were very common, and mostly on the scalp and the face. Next. Most patients did not require laboratory testing, but 77% of the patients required imaging, including radiographs, CT scan, and ultrasound. And hence, coordination with the radiology department is essential for accommodation, staffing, and expediting the results. 10% had major findings on imaging, and 28% required restoration. So having a dedicated area in our ED was helpful to expedite care and minimize crowding. Pain medication, in addition to tetanus vaccination, were most commonly administered. And most patients were treated in the ED and discharged home with an average length of stay of 1.9 hours, and the rest were admitted, some to regular floor and some to a critical care unit. 8 patients required major surgeries, and mostly because of serious injuries. Next, please. Related to comminuted skull fractures, epidural hematomas, subarachnoid hemorrhages, ruptured globe, tripod fractures, mandibular fractures, other extremity fractures, retained foreign bodies and abscess drainage, ruptured testicle, and vertebral bone fractures. As far as for the cost per patient for inpatient was about $5,620. This is roughly, and for outpatient was around $414. Thank you.
Thank you, Dr. Tharwat, for sharing your data with us. It really reminds us the scope of injuries, or the spectrum of injuries that we could see during protests. And it's not just tear gas. Of course, trauma is an important component here. Can actually be from the tear gas use, and some of it be unrelated to the tear gas use. But that said, we have seen a lot of tear gas use recently in the US, as reported by the New York Times in a recent article published yesterday. This use of tear gas has been really significant and hasn't occurred, according to the New York Times, since the 1970s in the US. Now, these chemicals that are called tear gas are not really gases. And that's an important misnomer. These chemicals are usually chemical irritants, and many of them are actually in powder form when they are used. This is why it's important to kind of step back a little bit and think about what are the chemicals we are thinking about in this scenario. There are a number of chemicals that have been developed and used at tear gas, the oldest of which is CN, which was developed in World War I and was actually not used in the battlefield, but then found its use in the common mace and used by law enforcement and the military over that period of time. Now, CN was replaced with CS, which is another chemical named after its inventors, chlorobenzalidine malonitrile, and CS is currently used in the US. Now, there are others. For example, one that is of particular interest to me is DM. DM is an arsenical, similar to lewisite, a chemical warfare agent that was also used as DM was also developed as a tear gas chemical. The US uses CS as well as OC. OC is oleoresin capsaicin, which is made of derivatives of pepper. Some people also refer to it as pepper spray. But remember that these terms of tear gas and pepper spray are often interchangeably used and misused. So when you think about these agents, you want to find out what is the actual chemical that we are talking about in the specific scenario. And when assessing the actual injuries of victims exposed to these chemicals, it's important to think about three different elements of the paradigm. One of them is the environment. So where was this chemical used? Of course, if it's used in a confined space, it will lead to much more severe injuries to being used in outdoors or in an open space. The environment also affects the injuries when you don't have a route of escape. These chemical agents, when used during protests, can cause severe injuries, especially if not used properly. Certainly having an escape route is important. And how close was the chemical release to the crowd? And how did the crowd react to this chemical plume that is being released in their environment? The second thing you want to think about is the agent itself. Was this used, which chemical was used, and how was it deployed? Did the law enforcement utilize a rocket launcher, and did they utilize that rocket launcher or that device launcher properly? Because if the projectile is fired directly at the crowd, it can cause severe traumatic injuries, as described by Dr. Tharwat Al-Zahran in her presentation. The chemicals themselves, in general, have a rapid onset of action. So typically these chemicals will have a rapid onset within a minute, so seconds to maybe 60 seconds for the onset of action. And the duration of action is self-limited. In general, within 60 minutes, the effect is subsiding. However, you do have some lingering effects that may last 24 hours or more than one day, especially if the exposure amount was severe, as well as the victim characteristics that could influence the duration of the symptoms. Specifically, people with asthma or chronic obstructive pulmonary disease or cardiovascular disease may be at risk for more severe injuries. Other factors to consider are victims at extremes of age, young children and those older than 60, those who have ocular diseases, and those who are wearing contact lenses. All of these victim characteristics are important in our paradigm assessment. Now, like I said earlier, these are chemical irritants with three major organs where they have their effect. The first one is a respiratory organ. Basically, we can see effects that range from the upper airway to the lower airway and affect patients at various degrees depending on the dose that they receive, as well as their specific characteristics and comorbid conditions. You do see cough, shortness of breath that is occurring after exposure. You do see burning in the nose, burning in the eyes and throat and chest. Those are usually, like I said, self-limited and resolve within 60 minutes. The cough may linger for a day or two, depending on the patient, the dose, and other factors. Now, those patients that have asthma or chronic lung disease may develop more severe reactions. If you see bronchospasm in these patients, you may consider giving beta agonists as bronchodilators or even corticosteroids to decrease the inflammation. Rarely we do see severe complications with pulmonary edema or airway compromise, and even death have been reported from these exposures in the literature. And the long-term complications of exposure to these chemical irritants can occur. They are less well characterized and probably less frequent, but they could include entities like reactive airway dysfunction syndrome that we often see as toxicologists in our clinics when we see patients exposed to chemical irritants. The dermal effects of exposure to tear gas also is usually self-limited. It can range in severity from just mere burning to erythema, but can also be more severe and lead to blisters that look like second-degree burns. We also note occasionally a delayed dermal manifestation, which is more of an allergic type reaction, similar to allergic contact dermatitis and acute generalized pustulosis that can occur. These delayed manifestations may require topical corticosteroids or calamine lotion. The third organ that's affected are the eyes, and these effects are ranging again in severity, and they are usually self-limited, primarily with lacrimae, excessive tearing, eye burning, inability to keep the eyes open with blepharospasm, and then conjunctivitis and lid swelling. We can also have some more severe injuries, but they're not as frequent. A slit lamp exam is important after removing the contact lenses and performing an irrigation with saline or water. Some have actually recommended using blowing air into the eyes. Of course, you have to be careful not to blow more of the chemical in the environment and cause secondary exposure in the staff. The slit lamp exam should be done. To look for corneal abrasions or corneal ulcers. You can use fluorescein stain to look for these, and if you find them, you can actually prescribe topical antibiotics and mydriatics. Oral analgesics are recommended, but not topical analgesics in these types of injuries that will require follow-up by an ophthalmologist. Again, in summary, the management of these tear gas injuries that are often self-limited is removing the victim from the scene, preventing secondary exposure by protecting yourself and doing proper decontamination and supportive care. Now, I wanted to share some more information with you regarding the emergency department preparedness and response to a mass casualty incident with victims of tear gas exposures. And for that, I'll invite Bangkok to share data he has accumulated in his experience and the lessons that he has identified. Dr. Otong, go ahead.
Thank you, Dr. Kasi. I'm going to discuss about our experience on tear gas secondary contamination to our healthcare providers and about the what lessons we learned to improve our system later to prevent secondary contamination when more protests occur further several times from 2008 to 2013. And you can see in the picture that the tear gas was used in Thailand is CS only. There's OC as we experienced. And it happened the first time in August 2008, which is about 12 years ago. At the time, it was the first time in the country that tear gas was used. And we have no previous knowledge about the tear gas used before. And we have also little knowledge of emergency department preparedness and management of the victim at the time. So the first time it was used is in the night time, about 7 p.m. It happened in front of the house of the government, which is at the point A on the map, and my hospital is at point B on the map. And you can see it's just about 5 to 8 minutes away with the So when it happened at night, at the time, the EMT just rushed all the patients to my hospital without any notification and also without the scene decontamination. So what happened? When the patient arrived at the ED front door, they just transported the patient inside to the triage area. For the main patient, they were asked to change their clothing at the triage area, which is dry decontamination. But for women, they were directed to the bathroom nearby to take off their clothing and then take some shower and then come back to the triage area after they change the clothes. However, any of us inspected the female patient inside the bathroom if they thoroughly wash themselves. And you can see when they were decontaminated, they were sent back to the triage area, which is already contaminated. And after that, all of the patients were transported to the treatment area according to their severity. And noted that at the time, nobody can wear the PPE level C. All of them just use the PPE level D, like the plastic aprons, gloves, surgical masks, and protective glasses. Somebody wore the goggles as they did for the trauma victims, but not for the chemical contamination cases. And you could imagine what happened later. Yes, we have almost 100% of our healthcare provider contaminated with the tear gas that brought in by the victims. Most of the contaminated personnel is the EMT, that is followed by the nurses who take care of those patients, and other type of healthcare provider as well. And for those who had symptoms, 100% of them had eye burning and lacrimation, followed by nose irritation, rhinorrhea, skin burning, coughing, chest tightness, and even nausea and vomiting. Learn from this situation. We know that the tear gas actually is not a gas. It is solid particle, as Dr. Kasi already pointed out. And so dry decontamination is not adequate to just, decon the patient. We need the wet decontamination as well. And also, we know after the situation that the way we should set up the decontamination facility should be outside the ED, not inside the ED, because, this chemical can spread inside the compound and cause the secondary contamination. And from many protests from since 2008, 2013, we have observed that it took several days or even weeks for turmoil to escalate to the climax, and tear gas would be employed. So after the few episodes of protests, we decided to pre-set up the decontamination facility while situation escalating. And you can see that most of the time the protests occur in front of the government house, which is just 5 to 8 minutes away from my hospital. There's no way we can set up the decon facility on time before they arrive to the ED. So this method is best for us to pre-set it up while the situation is escalating. And also we know that we have to use at least the PPE level C for those triage and also decon the patient. And I would like to point out that sorting and separating patients according to their role is very important. Many times that we have police officers and protesters and also government supporters, they each one of them, could be our victims. So many times they came to the same ED, and sometimes we see that they fought each other inside the ED, and even we admitted them to the wards. They also fought at wards as well. So we need to sort them and also separate them into separate areas and also in separate wards as well. Not only for our team education and also team improvement, we also come together as a group and create this poster to educate the public how to prepare themselves when they need to join the protest, and so that they can help out each other to do the first aid and to leave the scene on time if they have seen the tear gas. For example, we advise them to wear long sleeve instead of the short sleeve shirt, wear pants, bring another set of clothing for change if they're exposed to the tear gas, and also bring swimming goggles and face mask, water, a lot of water, and plastic bag, just in case they need to change the clothing and then put it into the plastic bag and close and seal it. And if they have asthma or COPD, they should bring their own inhalers to the scene. And also, we have some recommendation for them when they see that the government are using the tear gas. They should leave the scene immediately and above the wind and at a higher place. Take off contaminated clothing if they exposed to the tear gas, something like that, and take off all the ornament, take off the contact lens, and rinse water to wash out any in their eyes. And you can see from the picture here, they are well prepared when we provided our poster to the public. They wore goggles, and somebody also used the P100, and they also brought their own normal saline to help out each other in the field. And we started to see fewer and fewer cases coming to the ED because they got the first aid already at the field. Thank you for your attention for my part.
Thank you, Dr. Thong. Thank you so much for sharing your experience. I think now we're going to turn it over to Dr. Wax and Dr. King, who will lead the Q&A session. Thank you.
Yeah. Thank you. Excellent presentations today, for sure. At this point, I'd like to open it up to the Q&A and invite Dr. King to lead the Q&A of the nephrology discussion. One thing regarding the last presentation, though, if any of you have had recent experience with taking care of any protesters suffering tear gas injuries, feel free to raise your hand and chat in to the box. We'd love to hear from you in terms of your recent experiences. So at this point, Josh, take it away with the Q&A.
Thanks, Paul. We have a number of questions for Dr. Barasch. There were a couple questions on kidney injury biomarkers, in particular whether NGAL measurement was available and what the cost might be. And Dr. Barasch, I might ask you to see if you can expand that into a discussion, brief discussion of some of the commercially available biomarkers. What might the emergency physician or medical toxicologist have available to them?
Yes, thank you very much. So NGAL has basically been approved in the United States for drug companies to test new pharmaceuticals and is not yet approved for general use. On the other hand, it is approved around the world in different countries. That's the degree of my understanding of that. The typical scenario is that a lab would receive a specimen from an emergency department, for example, would run the sample in a clinical analyzer for an actual number. The dipstick is a brand new tool that would give a qualitative assessment, and a dipstick, I'm not on the production end of any of these things. I wouldn't know exactly, but it's probably on the order. In the research world, I include KIM1, which is another very good biomarker that KIM1 comes up probably starting at 6 hours and peaks later in time, and maybe more prolonged later in time. They're dispersed in time, as you remember from the old days of using different markers in the heart and heart disease and in MI. So NGAL first, KIM1 later. In the US, the FDA has approved a combination of biomarkers known as TIM2 IGF binding protein combination. And we certainly can see one of those biomarkers being very active in kidney damage, but our feeling is that they probably arise from outside the kidney and then are filtered if there's damage to the glomerulus and to the reabsorptive mechanisms. KIM1 and NGAL, in contrast, are very much made by the kidney itself and are deposited in the urine. So this is it is not a brand new area, but remains incomplete because of clinical availability of NGAL and KIM1. TIM2 IGF binding protein is probably available. And again, I think it's going to be a very different set of ideas because it seems to not come from the kidney, but outside the kidney. overall, I think that these markers are especially important in emergency room settings because of the time constraints and the pressurized situations. For example, let me give a best example that I've been thinking about. In a disaster area, for instance, in the earthquake in Haiti, where people were left outside or under rubble, an elevation of creatinine could be rhabdomyolysis for sure due to trauma, but it could also be exposure to the elements, lack of ability to get the food into water in such a disaster area, and creatinine can be elevated. And consequently, the biomarkers will tell the difference between a creatinine elevated due to volume depletion and that due to tubular injury. The U.S. Army has shown that NGAL works for them with a dipstick. They published a paper on it. They show they like it better than the other biomarkers in their hands and their particular use. So I think we're looking at a more sophisticated future where the injury biomarkers will be measured and then the creatinine will be compared, and the combination of the two will give a sense of injury and functional loss at the same time. In much the same way as I see one of the questioners online said, in much the same way of liver function tests, AST or injury markers if released to the serum, but of course, lack of coagulation factors or lower albumin is a mark of organ failure, as is elevated bilirubin. So I think we're going to have that sophistication in the future in the kidney.
No, thanks, Dr. Barasch. As a nephrologist, I'm very eagerly awaiting, clinically available NGAL testing. Some other questions were focused on whether these kidney injury markers might be useful to assess renal function in the more chronic setting. The example given was post-nephrectomy. And I'll also add to that for settings where toxicologists practice where patients are being followed for metal toxicity. For example, lead or cadmium, we commonly follow albuminuria, and whether or not these assays have any utility in these subacute or chronic settings.
Yes, thanks. So in terms of chronic disease, and in terms of after nephrectomy and or a donor, and what happens to the remnant kidney, or after a disease like hypertension, diabetes, which leaves chronicity, no, the biomarkers that the KIM1, NGAL, and TIM2 IGF combination are much more sensitive to acute changes in damage. In fact, a creatinine that is elevated but yet stable, where there's no sort of urgent activity in the CKD, gives a very slow progression to adrenal disease. The biomarkers that I've talked about are very limited, if not negative. People have attempted them. There is literature on it, but what I'm talking about is values that go up 10-fold, 100-fold, 1,000-fold in some cases in the acute setting, whereas in chronic disease, they could be much more limited. The second question is of nephrotoxins, and I said that NGAL and actually KIM1 have been okayed by the FDA for drug companies to test for nephrotoxicity, to spot nephrotoxicity in the pipeline of making new medications. Along those lines, some metals have been tested, and the best studies are on cadmium toxicity, where Dr. Bonventuri at Harvard has shown that one is a good marker of the degree of cadmium toxicity. Cadmium, I believe, is taken up by the proximal tubule and causes damage there. And the KIM1 biomarker is made in that segment of the nephron. NGAL is made downstream in the other segments. So he has shown, I haven't looked at cadmium myself, but he has shown a metal toxicity from cadmium. And that KIM1 is a good marker for metal nephrotoxicity.
No, that's really valuable and exciting information. I think that many of the metals toxicity we see are due to proximal tubular damage, as you mentioned, as well as most of the acute kidney injury we see in the toxicology world. We have some other questions related to COVID. The first is whether there is any evidence that urine carries live SARS-CoV-2 virus, and whether it could be an infectious fluid.
I'm certainly not the expert in this field. We will be making those measurements when our IRB allows us to. We have a collection of 1,000 urine samples from COVID patients, and that's certainly the first thing I'd like to turn to. There is a literature on the subject, which a few people have said they can detect virus, but a lot of people have said either no or very low titers. So I have a feeling, again, that albeit this traumatic loss of renal function, I think that viral infection of the kidney, direct infection that is, and presence in the urine will either be minimum or actually non-existent. Now, I probably will eat my words in time as I do these measurements, and other people do measurements. But as of now, we don't think so. Would be my best answer.
Oh, thank you. Another question was whether, or rather, I'll paraphrase, maybe to the extent which dialysis influences mortality of severe COVID. And I think that the questioner might be getting at whether patients who have severe lung injury have such a high mortality that dialysis is unlikely to make a difference, or whether you've seen some real saves from your ICU experience with patients with COVID-19.
So as I said, about 20% of patients, even 30% of patients have the possibility of coming off dialysis. It could take up to a month. The materials that have been examined by biopsy have shown what would be called classical AKI, with classical tubular injury, and of not necessarily the most severe forms. We think this is cytokine mediated. So the overall sense from pathology and the overall sense from patients and their histories is that there will be saves, and the saves and recoveries will be perhaps in the most severe cases, maybe on the order of 20, even 30%. So it's worth investing in dialysis and allowing at least 2 weeks to maybe 3 weeks to pass and then to reconsider. As I've said, during the peak of the COVID events, people were put on the CVVH, the small continuous machines, intermittently, 12 hours on, 12 hours off, or 1 day on, 1 day off, in order to spare resources. But we don't feel that withholding therapy would be appropriate at this point.
So I would concur. We have not seen nearly as many patients as you have in New York, but we've had at least a few dozen who have gone from CRRT to hemodialysis to leaving the hospital, and a number of those patients have left off dialysis.
Yeah.
Lastly, I'll ask one final question about COVID. In the event that we see a second peak as we approach fall, or as social distancing measures are limited, do you have any practical advice for hospitals and providers preparing for this surge in dialysis patients? We ran out of 0K dialysate at one point. We had to put somebody on ECMO on hemodialysis for that reason rather than CRRT. And whether the experience that New York had could inform the rest of the nation.
I think that that given the first round, and again, my colleagues here are publishing right now sort of their guidelines. I thought some of those papers are out from Columbia already, but I think that the overall sense that I get is that, having gone through the first wave, that it is possible to calculate the exact requirements for, as you say, the dialysate fluid, the number of machines, the requirement for nursing, for nephrologists, and for PAs and other healthcare providers per patient. I think that we have enough experience to say what it will be and what it will cost, and the methodology to share machines and so on is clearly been learned. And so I think, I mean, God forbid a second wave, and the number of patients, to the order of dozens a day, is almost inconceivable. We hope not to see that, but I think there's a lot of learned experiences here that will make any future waves more smooth sailing in terms of what we do as physicians and nurses and PAs and so on.
I think there's one more question to mention, and that is whether you've seen any evidence of thrombotic microangiopathy causing kidney injury in patients with COVID.
I think that what I hear from my colleagues, the various biopsy series are negative. You would think so, given the clotting disorders, but I don't think we have evidence of that.
Okay, I think that, and lastly, and you may have addressed this before, is whether there's any evidence of NGAL expression in chronic kidney disease. Yeah.
So in the AKI. So I haven't looked at the urine from the COVIDs yet. I as I say, I hope to shortly. I have looked at the tissues though, for NGAL and KIM being my favorite two markers. These markers are responding briskly to acute events on the order of hours. The clock is ticking once an acute event occurs. NGAL goes up 2 to 3 hours, may peak at 6 to 12 or maybe 24, and then by 48 starts to come down. KIM1 displaced a little bit later. So these are immediate, fairly quick response genes. When it comes to chronicity, if creatinine is 2 today, and let's say 6 months from now is 2.2, and then a year from now is 2.7, we do not see these types of markers in the urine. I know people have studied them. I know there is some data out there, but we don't see any brisk responses. Now, having said that, if there's acute injury on top of chronic injury, or the patient is progressing very rapidly to end-stage renal disease as a result of their intrinsic disease, the creatinine is simply going up week after week, then we will start to see the markers again. So in the parlance of my pathology colleagues, these are activity markers, not chronicity markers.
All right, well, that's the last of the questions for Dr. Barasch. Thank you again for a fantastic talk and discussion. I'll turn things over to Dr. Kazi.
Thank you, Dr. King. Dr. Wax, would you like to moderate any questions for the rest of the talk or conclude?
Yes, thank you. And again, great Q&A, Dr. Barasch and King. So just a couple final questions, which can be addressed to the latter speakers. And one of them came up about the use of the N95. I mean, we've heard so much about N95 with viruses. Masks are used for toxic gas exposures as well. Dr. Othrang, any advice about the N95 being sufficient enough to protect against tear gas, or are there other protective masks that you would otherwise recommend?
Okay, the best one would be P100, but because the size of the CS particle is about 0.5 to 2 micron, and the N95 can filter any particle larger than 0.3 micron. So the answer is yes. It can filter the tear gas, the CS gas. And because all of the tear gas, they have low vapor pressure, so I think the N95 should be okay. And actually, at my hospital, we instructed our healthcare provider for the decon team to wear the P100, but they told me it's so difficult to wear, so they actually used the N95 instead. But none of them had any secondary contamination from wearing the N95 to decon the patient at the hospital. But I'm not sure if you wear the N95 in the field, but in the open air, it should be okay. But if in the confined space with higher pressure, the problem is probably it's gonna, maybe it's difficult to say if it's okay. But in the field, in the open space, I think N95 should be okay.
Okay, thank you. And the last question for today, again to Dr. Athong, about the wet decontamination. Clearly, setting up for wet decontamination is an order of magnitude more complex than simple dry decontamination. Is there studies or a body of research suggesting that in the setting of these tear gas agents, that the wet decontamination is preferred, and without going through the wet decontamination, this would put hospital staff or others at risk?
We set up the decon facility, and everybody that need to be coming to our ED have to be decon first. And water, CS is not water soluble, but it can be hydrolyzed by water. And at the pH of 7, the half-life of the CS is about 15 minutes. With the pH up to 9, it can reduce the half-life of CS to just 1 minute. So yes, everyone should should do the wet decon with soap and shampoo. And initially, it's gonna cause burning pain, but with copious water, it can reduce pain, and the half-life will be shortened a lot, from 15 minutes to 1 minute. Yes, so wet decon should be the one that every patient should receive before going to the ED.
Okay,
and I would add, Dr. Wax, I would add that it's important to remember to consider where is the victim exposed compared to the emergency department. So I think Dr. Athong's experience was particularly interesting because of the proximity between the protests, the tear gas release, and his emergency department. So hydrolysis, was still occurring probably, and this the powder was still releasing, the vapors that would interact with the patients and the staff cells, mucous membranes.
And also, you asked me about if the healthcare provider would be safe to decon them. Yes, if they wear the PPE level C. But again, my staff did not like to wear the spray suit of the level C, so they just they wore the surgical gown. It's okay as well, surgical gown, and to cover most of the skin area, and also with goggle and also N95 if you are out of level C PPE.
Okay, great. Well, thank you. So I'd just like to thank again the faculty today, Dr. Barasch and Drs. Athong, Elzon, and Dr. Kazi, and our guest moderator, Joshua King. Thank you so much. Next slide. Again, the webinar will be posted on our website on Friday. Any questions, you have some info at acmt.net. You can contact us. Next slide. And finally, we'll be continuing our webinar series next week. We have another exciting talk on recommendations for improving national nurse preparedness for pandemic response, early lessons from COVID-19. Dr. Tanner Venema from the Johns Hopkins Security Center recently first authored a report about nursing preparedness. It was just released last week, and we are very fortunate to have her be able to address our webinar group next Wednesday. That's June 24th at 3 p.m. Thank you very much, and have a good day.